than playing catch up later. The second broad category for freeze all, the first one is safety, where no questions asked. The second one is necessity. And under this title comes those indications. If during the course of stimulation we were surprised by a patient who produced large number of follicles, so if we find 18 follicles above size 11, then we will have to think again and consider freeze all at this stage, not from the outset. For any unforeseen circumstances, so if for whatever reason our nurse or our doctor scanning and found a decent sized polyp of anything above 1 centimeter or 2 centimeter, then probably it will be wise to freeze all. Sometimes hydrosalpinx that has not been seen before, but because of the effect of ovarian stimulation on the endosalpinx and a lot of secretion being produced, it has become prominent. Then we make a decision to freeze all until the environment is right, and we do clipping of those hydrosalpinges later, and then we can do a bland, healthy frozen embryo transfer. The other necessity is pre-implantation genetic testing. And for years, we have been doing pre-implantation genetic testing using day 3 biopsy. And I have to emphasize that when I say pre-implantation genetic testing, it is to do with hereditary genetic diseases, where they are autosomal recessive, autosomal dominant, or hereditary predisposition for cancer susceptibility, or late onset conditions such as Huntington disease and other cancer susceptibility genes. The fourth item, which is a necessity, is fertility preservation for various reasons, one of which I already mentioned, that out of necessity, if you find that there is a lot of fluid in the cavity of the uterus, or the guy, the couple concerned, they decided they are not really ready to freeze now, or they would like to just get more embryos so that they can plan their future for later, or a patient has large fibroids that appear to impinging on the cavity, and the waiting list would be 6 to 9 months, and by the time she recovers from surgery 6 months, she likes to be absolutely clear that she has embryos in the freezer, rather allowing then the biological clock to keep ticking. So these are the two concepts under which we do freeze all. But recently, as you are all aware, people suggested that if you separate ovarian stimulation and the hormonal environment that it creates, particularly for the endometrium, and you do what is called as segmentation or dislocation between ovarian stimulation and embryo transfer, could we improve the success rate of the process in the frozen compared with the fresh? And that momentum has been given a huge amount of force when there were 3 large randomized controlled trials published in New England Journal of Medicine, 2 from China, and the senior investigator was Rick Legro, and 1 from Vietnam, and the senior investigator was Ben Moll. And all of them pointed out to equivalence at least, except for 1. When it was done in PCOS in a Chinese study, it suggested that you get more success or more babies with frozen compared with fresh. I have personally some reservation about this study, but nonetheless, it is safe to take it from safety perspective. When you freeze all, the patient will not be disadvantaged in terms of success, and we can debate whether it is higher or not. But if I take one of the Chinese studies, and this study looked at ovulatory PCO, it's not the typical PCO, it's just there is ovulation. And the randomization happened late in the day, and that's not a good methodology. 4.5% in the frozen embryo transfer arm and 3% in the fresh embryo transfer arm did not have an embryo transfer to start with. 95% of the patient had double embryo transfer. They were happy to allow 30% twin birth rate, which is not extrapolatable in the civilized world now. 15% protocol violation. 50% live birth rates after cleavage stage transfer, which again, not many people use cleavage stage nowadays, and to do embryo transfer with 2 embryos and to get 50% live births, one would probably think of some selection bias in this case. But more importantly, and worst of them all, that when ovarian hyperstimulation need to be prevented, in this study, human chorionic gonadotrophin was used as a trigger. So not just me, but other people have reservation about this study. So accepting that the notion was in favor of going with freeze all by everybody, but we at Guy's and St. Thomas's, we exercise our own judgment. So we do not normally go with the flow until we are reassured from robust evidence that what we are about to embark on is substantiated. So all of you have heard that the high estradiol level during stimulation is bad for embryo implantation. I can show you here data from the SART data for patients under the age 35. These are the good prognosis young patients, where year on year they are getting live births of 40%. That is a baby to take home, with an implantation rate per embryo of 40%. Now, if you subscribe that estradiol is really so harmful, you would not get anywhere way near those great figures. So it's important to just keep a little bit of reservation about the notion that everybody is going with. The other reservation we have, we highlighted in a human reproduction update review we published a few years ago. My colleague, Julia Kubika, who did her PhD in cryopreservation, and Alan Thornhill, who was the lab manager of our unit at the time, and myself, we put together our assessment of the impact of freezing on the embryo and the physical factor and the chemical factor, and there are also potential toxic effects, as we heard David Gardner was talking about yesterday, about using antioxidants and what have you, and also now the talk about prolonging the period of storage, particularly with vitrification, could be having effect on the chances of success when these embryos are used in 2 years' time. The other factor is money, because cryopreservation costs. There are costs for the material, there are costs for the time, there are costs for the cryoprotectants, there are costs associated. So we have to satisfy ourselves that the patients are getting something in return when we do it to increase success. When we do it to improve safety, it is more than worth it. But if we are to do it for success, we have to reassure ourselves that the patients are getting back value for money. Plus, there are some unknowns. Even now, we don't know for which patients to freeze all electively, not on safety ground. What happens if the embryos are not good quality? Is it clinically effective? Is it cost effective? Is it acceptable by the patients? How about the concern about increased proportion of babies that are large for gestational age with frozen embryo transfer compared with fresh? And we always remind ourselves by rule 1 in medicine, don't do harm or do no harm. So if there is any potential of harm, we might as well just keep going very considerately and wait until we have evidence that whatever we do is delivering on what we promise our patient. So that's what we technically call clinical equipoise, when we don't know whether freeze all is more effective or not. In any decent society, when you are not certain, it is not an indication to improvise. It's an indication to do the research. And that's exactly what we did in the United Kingdom. Our colleagues from Aberdeen, Dr. Abba Maheshwari, and her colleagues, and including us as principal investigator, got money from the National Institute for Health Research to do a randomized trial to assess clinical effectiveness, safety, and cost effectiveness of freeze all. Not for safety, but to assess the potential benefit. And there were lots of centers. Our center is one of them, and the recruitment is finished. And this result of this study will be published in ISHRA meeting next week. I am a principal investigator and co-applicant in the grant application. I have no idea what the result says, because it can only be unblinded and declared at the investigator meeting 2 days before ISHRA. So it is important to assess the pros and cons of freezing all for, say, indication other than safety. At Guy's and St. Thomas's, we don't freeze cleavage stage embryos. We freeze blastocysts. And you might ask why, and there is something to be argued for or against, but our logic is simple. Not every cleavage stage will make blastocysts. Why make a guesswork and not freeze the final product? A, you freeze less, and B, you freeze something that has 95% plus chance of survival, and you freeze something that has higher success rate. So you are not luring the patient into thinking that they have frozen material when in fact what they have may not survive the test of time. So that is what we do as far as blastocyst freezing. Here is our results, and that is as raw as they come. And I have captured them directly online from the Human Fertilization and Embryology Record System. This is months on months, and you can see in 1 month here we did 108, we have 47 clinical pregnancies. In another month, 85, we had 27 clinical pregnancies. So it's not all pink and rosy. But I did the calculation for you, and our clinical pregnancy rate for frozen embryo transfer over the year 2019, in actual fact, from March 2019 to February 2020, is 298 clinical pregnancy over 791 frozen embryo transfer, which constitute 38% clinical pregnancy rate per embryo transfer for all the frozen embryo transfer cycle in that year. That does not include the frozen embryo transfer for PGT, which I will cover separately. We did a study out of our work to try to see the impact of the outcome of the fresh blastocyst transfer on the subsequent frozen cycle. And as you would expect, if the first cycle resulted in a baby, the chance of the frozen is higher than if the fresh cycle was unsuccessful. And you can see here, we included 692 cycle in the one that had pregnancy, 936 that they were not pregnant in their fresh cycle, and the implantation rate is 36% for those who had success, but only 29% for those who had unsuccessful cycle. And here 38% for clinical pregnancy rate, 31% for those whose fresh cycle was unsuccessful. And of course, as you would expect, that is age related. If the patient is under 35, the live birth rate is 35 if the previous cycle resulted in a pregnancy, but it's only 30% if the previous cycle, the fresh cycle, was not resulting in a pregnancy. And the multiple pregnancy rate is comparable in both sides of the equation. Here is a little bit higher in the cycles where the fresh cycle did not result in a pregnancy because we replaced relatively more proportion of double embryo transfer. So that would account for the 16% multiple pregnancy rate. And that's what we like to see before putting the embryos back. That is the optimal endometrium. However you get it, whether it's natural or whether it is medicated, it doesn't matter as long as you can get a very inhabitable embryo. And I go back also again and again and again. For those who insist on doing hysteroscopy, I say, do you really need anything other than this endometrium jumping at you to say, I am free, I am innocent, don't poke me with any instrument? So what do we do when we do PGT? We use ovarian stimulation and we use agonist trigger because we're using antagonists. And we culture to blastocyst. We biopsy at the blastocyst stage, and then we vitrify the blastocyst and then wait for the result. It is very draining to any laboratory to do testing of every case every day. So we batch the cases and we do the genetic testing in a batch. And then the report will say this patient has 3 or 4 blastocysts suitable for transfer genetically. Then we prepare for blastocyst, and then we do single embryo transfer. That's not negotiable because it's not clever to try to avoid the delivery of a handicapped child due to the genetic abnormality, only to give them a handicapped child due to multiple pregnancy. So that's not great. It's not plain sailing. There will be some obstacles. With ovarian stimulation, the eggs could be few or could be of poor quality. The fertilization may be poor or no blastocyst developed and there is no biopsy. There is nothing to biopsy. The embryo quality may not be adequate for cryopreservation. With genetic testing, there could be a test failure or the results are uninterpretable. They're very rare, but we have to cover them. Or when we do the embryo, so particularly when the embryo quality is not great at the time of biopsy, it may fail to survive the sow. Luckily, it's not a huge number. Here is a cumulative live birth after trophoctoderm biopsy for PGD. In 2016, as an example, we did 390 couples started treatment. 89 couple had no embryo transfer. Had no embryo transfer. They did not have any genetically suitable embryo to go back. Their story ended. 82 had only one genetically suitable embryo for transfer. Here they had more than 2 or more genetically suitable embryo to transfer in a frozen cycle. Let's see what's the result. Those 82, they had only one embryo suitable for transfer. They had 20 of them had a live baby. Those who had more than one frozen embryo transfer from the same stimulation, 103 had live births. That is 70%. When you put the two together, the total number of live births was 123, which mean that we have 39% live births per couple starting the process of PGT and 54% per couple reaching the embryo transfer. So why I mention that, it testifies to the effectiveness of the process of freezing, the process of thawing, the process of frozen embryo transfer, because if you can get 54% per couple reaching transfer for a process that is PGT, that has a lot of attrition, it's not a bad result. Here is the patient who did not have any embryo transfer. 3 had no response. 2 had no eggs suitable for ICSI. Those 13 had no fertilization or cleavage. 28 had none suitable for biopsy. Here, 33, they were not genetically suitable for embryo transfer. 4 failed to survive the thaw. So the cumulative chance, as I mentioned to you earlier, is when you look at the rearrangement. The first one was monogenic disorder. Here for translocation, the chance even higher, 63% per couple reaching embryo transfer. So the condition makes a difference. When it comes to freeze all for everybody, the data from SART suggests that if you freeze for patients who produce 15 eggs or higher, freeze all is comparable to fresh. That's not statistically significant, so at least they will not be harmed. When it is 6 to 14, fresh embryo transfer has the edge, but only just. But when you freeze all for patients who produce only 1 to 5 eggs, the outcome is far worse with freeze all compared with the fresh embryo transfer. And I think this slide might be mentioned later in other contexts. When you compare the fresh versus elective frozen embryo transfer, there are studies now that putting things together that suggest live birth rate and cumulative live birth rate in 5,000 plus patients indicate that the cumulative live birth and the live birth rate overall is comparable. However, we need to keep in mind that chances of macrosomal baby are higher with frozen embryo transfer. And until we sort out what is the health implication is for this phenomenon, it is important to do it when it is safety and when it is necessity. Because look at here, preterm labor is better with spontaneous conception, the rate is lower. With fresh transfer, it's a bit higher, but it is less with frozen embryo transfer. But look at large for gestational age. It is highest with frozen embryo transfer, and post-term is highest with frozen embryo transfer and spontaneous conception, and lowest with fresh cycle. Hypertensive disorders of pregnancy in the woman is increase in frozen embryo transfer, but that is being attributed to artificial cycle, as I might come back to this later. So if I wanted to summarize our position as to when do we do freeze for all, we do not do it for everyone. We do it for risk of OHS as a safety measure. It's not negotiable. Based on ovarian response, if we had a surprise where the patient had the ovaries full of follicles all of a sudden, then we have to respond. Some people freeze for raised progesterone level on the late follicular phase. We don't do that at Guy's and St. Thomas's, and I can happily explain why. Patient who had implantation failure before, you might find the odd paper or two in the literature. They are very weak and not a great design paper suggesting that it can be helping patient with recurrent implantation failure. I fail to see how. For PGT, as I explained to you, and people suggest that it could be helpful for slower developing blastocysts for synchronization. Nonsense, it doesn't. The slow developing blastocysts will not do as well in any case. There are people who do it for endometriosis, then they can freeze and then do the suppression if the jury is still out. To improve obstetric or perinatal outcome, we don't have a clear indication and we need to be cautious. So this is, we said that quickly if I have time. Do I have time, Mr. Chair? A few minutes? Okay, I'll assume the answer is yes. So how do we prepare the endometrium for frozen embryo transfer? It is clear. We either use unmedicated natural cycle or a modified natural cycle, where we do a little bit of tiny bit of medication. Or otherwise, we use medicated cycle either with GnRH agonist suppression or without GnRH agonist suppression. The natural cycle just goes with physiology. The first cycle, the first part of the cycle, there is estrogen for the proliferative phase. The second part of the cycle has estrogen and progesterone as it's produced by the corpus luteum. So for the natural cycle, we ask the patient to use the test from day 10, test every day. And when the tests say positive, she contacts us. We will have scanned her on day 10 to make sure that the lining is fine and that she has a leading follicle. And when she phones us with a positive LH surge, we schedule her frozen embryo transfer 7 days later. So if she phoned me today on Friday to say her surge is positive, I'll bring her back on Thursday next week to have her embryo transfer. And that is based on all the physiological steps of the cycle, as you all know. Modified natural cycle, we will scan the patient from day 10. When we have a follicle size 17 millimeter and the endometrium is above 7 millimeter, we would give HCG injection to induce ovulation and emulate LH, then we can control it. That's what we call natural modified cycle. And it is here, you do the scanning, you see the follicle, you give the HCG, and 7 days later, you do the embryo transfer because it replaces the LH surge that we base our natural cycle on. Everything has ups and downs, pros and cons. If you do natural cycle, it is safer, it is easier, it doesn't involve medication, you are using the hormones, it is not expensive. And health-wise for the mother, it is the healthiest approach. The downside is you will need to be on watch, you can't plan. The lab needs to be 7 days a week because you can't play with the timing. And you have to be available if you are to do your procedure yourself for your patient. So that is the only downside. And this is the true natural cycle where you could bring the patient early if it suits her to come early. And then you give her another scan to establish that the endometrium is fine. You do the LH monitoring. We don't do it in blood. We rely on urine testing and it's reliable and it's tried and tested. If we are to do the modified natural, when there is follicle 17 millimeter and the endometrium is fine, we give HCG and then we do and in both cycles, whether it is natural or modified natural, choice or using luteal support is really optional. It is not particularly necessary. But for reassurance of the patient, some will prescribe progesterone with natural cycle when the corpus luteum is more than adequate, and some will prescribe progesterone when the HCG that was given to trigger ovulation should be helpful. Either way, both are correct and both are safe. What is the best stimulation, whether it is artificial, natural cycle, true natural, modified natural, they are all comparable, whether it is true natural or modified natural. The programmed frozen embryo transfer will be either down-regulated or not down-regulated. If it's now down-regulated, you use decapeptyl from day 21. The patient will bleed. From the second day of the period, you start giving her estradiol, 8 milligrams per day. When you reach the right thickness of the endometrium, you continue the estrogen and you add progesterone. You will use vaginal, you can use intramuscular, you can use oral, whatever suits you. But at Guy's and St. Thomas's, 85% of the patients that we treat will use vaginal progesterone. Medicated frozen embryo transfer without Dow regulation, it is not necessarily that you need to do suppression. You can just start the embryo transfer, the preparation from the second day of the cycle, day 1 to 2. You give estradiol 8 milligrams per day, or you can use the patches if you have any issue with the side effect of oral estrogen. And sometimes people advocate vaginal estrogen if the endometrial thickness is inadequate, total non-supported by evidence, but it makes us feel better. And here is day 2, estradiol valerate. You can use 6 milligrams, but now we use 8 milligrams. You scan on day 12. If the endometrium is 8 to 12 millimeter thickness and it's nice and healthy, there is no surprises, you can start progesterone for 5 days. And on day 6, the patient comes and have her blastocyst defrosted, allowed to show sign of expansion, and then put back into the uterus. The medicated with GnRH Dow regulation, it allows a bit of flexibility, and it uses the long protocol, which give patient side effect, but equally you can be almost sure that there will be no ovulation. Let's just move on. Endometrial thickness can be an issue. In some patients, the endometrium can never be as good as others, but this is not something you can control. And the pregnancy rate, ongoing pregnancy and live birth rate between artificial cycle and natural cycle, there is nothing to separate, but safety will always be on the side of natural cycle. Here is our clinical pregnancy rate with frozen embryo transfer per age. Under 35, it is 42%. 35 to 40 is 30%. Above 40 is 14%. And this is the cumulative live birth that you showed earlier. And this is our concept, practice, and result from frozen embryo transfer. And I will be happy later to take any question regarding to what we do. Thank you.